Hello everyone, we are here in a cath lab, Pediatric Cardiology Division, Cairo University. We will present one of the interesting case with an enlarged ASD, me, Hala Agha as operator, and Dr. Sahar Shakir, Dr. Osama Abdelaziz, Dr. Ahmed Abdel Wahid, and our great team, Dr. Dua from anesthesia team, and Sahar, our nurse, and Muhammad and Rami, our technician.
Now we will present our case. The case is 11-year-old boy accidentally discovered large ASD secundum since 3 months. Regarding the physical examination of the patient has average body weight and body surface area, normal vital signs. The cardiac examination revealed no signs suggestive for cardiomegaly and there is quiet precordium. By auscultation, there is normal S1 and white fixed splitted S2. There is no murmur and the apex is located in the fifth space mid-clavicular line. Chest and abdominal examination are normal. There is no hepatomegaly. There is here we will present the ECG of the patient. The ECG is sinus with average heart rate around 90, normal axis. There is normal PR interval, no prolongation of the PR interval or the QRS, no bundle branch block. There is RV hypertrophy, chest X-ray, normal CT ratio, and there is no lung plethora. Thoracic echocardiography will start by subcostal for a chamber view. There is large defect central in the septum. From the classic bicaval view, the defect is not appearing by the classic bicaval view, but with some angulation anteriorly when we are approaching the aorta, the large defect appear by color Doppler by some modification of the bicaval view. And there is still image by color. There is still image by 2D when we including the flimsy end of the defect. Here the apical for chamber view. There is a huge right atrial and right ventricular dilatation and average size LV and LA. The total septal length 5.2 centimeter. The patient has no pulmonary hypertension, estimated systolic pulmonary artery pressure around 33. By M mode, there is RV dilatation and there is no paradoxical septal motion. There is average dimension of the left ventricle.
So for fourth chamber view, there is a large secundum ASD, as we see here, with a good posterior superior rim. A total defect size is around 25 millimeter. As we see here, also it's a large atrial septal defect with adequate AV rim and posterior superior rim. Here we are measuring the total septal defect, including the flimsy rims. It's around 29 millimeter. Again, around 30 millimeter defect.
What is this view?
When we are going to the bicaval view, the defect becomes smaller in size. So it's mainly it's going more to the anterior part. Again, here this is the proper bicaval view, showing adequate SVC rim and adequate IVC rim, and the maximum dimension in the bicaval view it's around 20 millimeter. Here. Then we'll go to the short axis to show the aorta. Here. In the short axis, as we see, there is no rim, no retroaortic rim. Actually, it's a bold aorta.
So you think, Dr. Osama, it is an oval defect rather than round defect?
Yeah. And actually, it's a large defect with dimensions of like 20 by 30 millimeter.
Okay. Thank you, Dr. Osama. What is our plan, Dr. Sahar, for this challenging cases of a 11-year boy and with total length 5.2 and an oval defect?
The whole team, we were discussing this difficult case in different circumstances. We would have did a balloon sizing, but for cost-benefit reasons and financial, we decided to use Occlutec size 30 ASD device and Platzer for closure. And we're going to start the procedure now, saying in details every step we are going to do. Now we're using a 6 French catheter, multi-purpose end inside, and we're introducing it over a wire.
يلا الواير يسار واير واير يسار الواير قبل اوكي.
Our aim is to cross from the right atrium to the left atrium and try to lodge it in one of the upper or middle right pulmonary veins. ممكن حد يرفع شوية الترانسوسوفيجيال.
Okay.
We're using an exchange wire 0.035 by 260 and we're lodged now.
لا عاوزاه في الأبر.
Okay.
Okay. In the upper.
In the upper right pulmonary vein.
Okay. Flushing system is very important and dilator inside the long sheath.
Okay.
Without any loop inside the right atrium, and then I will draw the short sheath and carrying of the wire inside the right upper pulmonary vein.
We'll make a bigger snip for introducing the
Okay,
long sheath
please,
12.
please put the long sheath inside the wire, and I will prepare for the introduction.
Holding the wire for the long sheath when it's introduced.
And after putting the long sheath and withdrawal of dilator, to have a look by TE. Okay. Have a look by TE now, and we are
Genie
putting the
triple
triple way.
Okay. We make sure there is no air inside the system, the long seat, and then we place a triple valve for bleeding.
Okay. We stop any bleeding. اوكي. انا بايباسنج الديفكت ولا لا يا احمد؟ وريني ايبيكال فور تشامبر.
وريني الديفايس يلا. احنا we're gonna use this as a try of manipulation، بس هي مش هتخش قوي، بس هنحاول نعملها
طيب
كده
طلعوا لي
عشان
ال-
two different companies. اديني الديفايس. يلا يا صاحبي.
نعم، في الرايت اتريوم ولا في الليفت؟
تقدر تجيب زوم عليا ثانية واحدة. that's the
ده من غير
ocular-
فلاش كده يا
that's-
جماعه.
that's the
we repeat our procedure. Okay, I got it. I got it اهو.
تمام.
Okay.
So
ثواني we are adjusting ourselves.
now we change the
وفي اللاترال حاجة بوستير.
the plan of our
Okay.
procedure. And
أبص لحضرتك
we are
بالتي.
aiming to the upper
وقتها.
place.
We remove this.
Okay. Now deploying the left atrial disc.
We are away from the septum.
Yes, from the septum,
From the
still away.
septum, so we need to pull the whole system towards the interatrial septum.
Yeah, the direction looks okay. Yes, now in the septum.
Direction is good.
Yeah, direction, very good direction.
By
So
plane,
we
it's
almost on
looking
the septum, so we'll
posteriorly
start.
and anteriorly, and that's
Yes, very
deploying
nice.
very
Yeah.
nice.
Very nice here.
Right
Yeah.
atrial disc.
Let's to have please have a look here. Open the paddle.
اديني شاش يا سحر بسرعة شاش كتير.
Now we'll deploy our system. Sahar?
We are.
No, the other one is not.
Mhm.
Okay. Well and good. Go down.
So go to the T again.
Okay.
So we'll start with the 4-chamber view.
عملنا حاجات ما
Yeah,
بتعملش
looks
خالص.
looks perfect.
Okay. It's studdling over the
Yeah.
aorta. Please increase the depth more. Yeah.
And actually,
Yeah.
it's only a minimal intra-device leak and no residual defect.
I think it was a good choice.
Yes, the
despite
size,
we didn't
yeah.
have any balloon sizing, and it was a big one that looked oval. But I think the size
Yeah,
is
as
very
well.
satisfactory for all of us.
Exactly.
And I think
Tricuspid is okay.
yeah. Occlutec device is very nice device
and a large defect,
for
yeah.
a large defect. And especially if we are not ballooning, and this is our institutional policy, except with aneurysm and with large defect. I think very good choice, despite it is an defect underestimated by transthoracic, but by TE, we properly choose the proper device. As we measured by the maximum diameter, it was 28, and we choose 30. So usually, if we have a large defect, we increase the size around 3 to 4 millimeter above the TE size. Thank you, Dr. Osama.
You're
Thank you,
welcome.
Dr. Sahar. Thank you, Dr. Ahmed.